Hello, my name is Ruben Mesa, and I'm one of the hematologists at the Mayo Clinic who focus on myeloproliferative neoplasms, and will be presenting the new NCCN Guidelines in myelofibrosis. My colleagues and I on the NCCN Guideline panel felt for these inaugural guidelines we needed to tackle a segment of the significant efforts for these individuals. We started with guidelines regarding the diagnosis and treatment response in myelofibrosis, PVERA, and ET, as well as disease burden and treatment planning in all three of these diseases. We'll be focusing right now on the treatment guidelines in myelofibrosis, and in the future, upcoming guidelines for treatment in PVERA and ET, as well as diagnosis and treatment of the atypical MPN. The MPN workup at a high level, we endorse the utilization of the WHO criteria for all three of these entities to assess disease burden through symptom assessments through structured questionnaires such as the MPN symptom assessment form, as well as utilizing prognostic scores in myelofibrosis, the IPSS at diagnosis, or the DIPSS in subsequent encounters. Starting with individuals with myelofibrosis who are low risk by IPSS or DIPSS, we assess symptoms using the MPN-SAF symptom score, and we divide therapy by those who are asymptomatic versus symptomatic. Those who are asymptomatic, we feel that observation remains a reasonable option, but certainly there are clinical trials for these individuals that would be reasonable. We monitor for signs and symptoms of disease or progression, and if they progress or become symptomatic, we drop to the next tier. Those who are symptomatic, we feel that options including JAK inhibition with ruxolitinib, impact with interferons, or clinical trials are appropriate. And as a theme with all of the guidelines, we monitor for response as well as signs of progression. Those that have disease progression, we move to our next tier of recommendations. Intermediate 1 risk patients, again, we assess symptoms, and the options are observation if asymptomatic, ruxolitinib if symptomatic, clinical trial, or allogeneic transplant, perhaps in very select individuals with higher risk molecular features. Monitor for response as well as progression, and if people progress, we look at intermediate 2 and high risk engagement. Those with intermediate 2 or high risk represent the majority of patients with myelofibrosis. We feel that the first key question is discussion regarding stem cell transplantation. Those that are appropriate transplant candidates and have a donor, that should be considered either straight away or as part of a clinical trial, including transplant. Those not a transplant candidate who have symptomatic anemia alone, we have separate guidelines for managing anemia. Those who are not a transplant candidate, we then stratify based on the platelet count. With currently one approved therapy of ruxolitinib, those individuals with a platelet count less than 50,000, we consider a clinical trial or very reduced doses of ruxolitinib under 5 milligrams twice a day. Greater than 50,000 platelets, we utilize ruxolitinib or a clinical trial. We monitor for response, signs of progression, and try to optimize utilization of the therapy. Those who progress, we have a separate algorithm for those who have advancing disease towards acute leukemia and request restaging of the marrow and blasts. The blasts, whether they be 10% or 20%, the key question is transplantation. If they're a transplant candidate, we try to cytoreduce with either intensive induction chemotherapy or hypomethylation. Those who are not a transplant candidate, we have a more suppressive approach or consider clinical trials. I would conclude by our take-home points saying that assessing patients with myelofibrosis involves identification of risk and symptoms when coming up with your treatment plan. Second, ruxolitinib is currently our main medical therapy for myelofibrosis, and its utilization is balanced against the consideration of allogeneic transplant in patients with higher risk. Finally, patients with accelerated or blast phase myelofibrosis face a big therapeutic challenge and continue to be an area of unmet need. My thanks for participating in today's program.